Good evening, everyone. My name is Grace Spadafora. I'm president of the Vermont Academy of Science and Engineering, and I'm delighted on behalf of myself and my fellow board members to welcome you to this year's annual fall meeting. I want to direct a special welcome to our keynote speaker, Dr. Mark Levine, Commissioner of the Vermont Department of Health, who has taken some valuable time away from his regular noontime TV sessions to be with us, to talk to us about the COVID-19 pandemic that we are all experiencing. I'm not going to take much time to tell you about our organization, but I would like to direct you to the Vermont Academy of Science and Engineering's newly updated website. You can go to this address and learn more about us and the grants that we have to offer to K through 12 science educators, and more, even more so, by going to this website. So this is the agenda for the evening. Given the unusual nature of the formatting of this meeting, which was required to be remote, as you all know, I thought it would be worthwhile to take a few minutes to discuss the logistics of how the meeting will run. First of all, I want to make you all aware of the fact that this meeting is being recorded. Also, this meeting would not be possible without the assistance of my colleague at Middlebury College, Jonathan Kemp. He is the telescope and scientific computing specialist at the college who will be with us for the entire evening and navigating any technical difficulties we may be having. If any of you are having technical problems with accessing the screen, the shared screen, or the speaker, or problems with audio, Jonathan will do his very best to address those issues. The way to make him aware of the problems you may be having, the technical issues you may be having, is to enter those problems in the chat box. So for this meeting, the chat box will not be a platform for asking questions, but rather for entering any technical problems you may have. Jonathan will be monitoring that chat box very closely throughout the evening. We encourage questions from our audience, especially during Dr. Levine's presentation. If you have questions, then you should type them into the Q&A box, which you'll find at the bottom of your computer screen, and then you'll be able to submit your question. We have several board members who will be looking through the questions they receive in the Q&A box, and they will, at the end of the presentation and during the Q&A session, present your questions to our speaker. I'd like you to note that VACE, the Vermont Academy of Science and Engineering, is a nonpartisan organization, and as such, we strongly discourage the use of the Q&A platform as a means to further any political agenda. We thank you tremendously for your cooperation in this regard. Okay, so that's a little bit about the logistics of the meeting. So now I want to spend a few minutes introducing you to our new inductees, our most recent 2020 inductees into the Vermont Academy of Science and Engineering. Lifetime membership in the Academy is by invitation only, and it is bestowed in recognition of distinguished accomplishment in the broadly defined areas of science, technology, engineering, and mathematics. The board of directors considers a number of criteria in addition to a sustained record of achievement in the STEM field, and that includes national and international reputation in one's discipline or in one's interdisciplinary area, as well as a commitment to advancing public knowledge and involvement in scientific matters. You will see that members can come from business, from government, from academia, but they must live or work in the state of Vermont to qualify. So without much further ado, I'd like to introduce you to our 7 new inductees for 2020. This is Bryan Ballif. Ballif's primary research focus is on the signaling mechanisms that regulate neuronal positioning and differentiation during vertebrate brain development. He uses a cellular approach to reveal proteins, their modifications and interactions with other proteins, all in response to acute stimuli or to various stages of development. In collaboration with Dr. Ebert, he also uses genetic and histological approaches to study retinal development in the zebrafish model. Dr. Ballif's broad training as a biologist has also promoted collaborations that he shares with his students, studying the molecular basis of human blood groups, viral proteins as potential antiviral drug targets, even pitcher plant mini ecosystems, and kissing bug blood meals to better manage Chagas disease. Welcome to the Academy, Dr. Ballif. Next, I'd like to introduce Dr. Francis Carr. Dr. Carr uses advanced sequencing and bioinformatic approaches to study the molecular mechanisms by which thyroid hormone receptor beta can block thyroid and breast tumor growth and progression. Specifically, she seeks to understand how thyroid hormone receptor beta activation by select drugs serves to improve tumor response to known thyroid and breast cancer treatments, and how it limits the development of resistance. Taken together, her accomplishments aim to mitigate treatment-resistant and/or recurrent disease, and so help the development of novel therapeutics in this area. Congratulations, Dr. Carr. This is Kyle Clark. Kyle is an engineer, a test pilot, and the founder of 3 companies, including Beta Technologies, that operates out of the Burlington International Airport. He and his team of engineers at Beta developed an electric vertical takeoff and landing aircraft called Ada that has been successfully flown and that represents what is likely to be part of the solution to environmentally sustainable flight into the future. Congratulations and welcome to VACE, Kyle. Now I'd like to introduce you to Dr. Christopher Francklyn. Dr. Francklyn is being recognized for his more than 30 years of work investigating the machinery of protein synthesis with a focus on transfer RNAs and their amino-acyl tRNA synthetases. In his lab, investigations of the enzymology of these tRNA synthetases has revealed their alternative moonlighting-like functions, which include a role in angiogenesis. Along with his collaborators, Dr. Franklyn's study of tRNA synthetase mutants supports tRNA synthetase involvement in peripheral neuropathies and in neurodevelopmental disorders. These unique functionalities of amino-acyl tRNA synthetases can foster the development of innovative therapies and treatment strategies moving forward. Congratulations, Dr. Francklyn. This is Greg George. Greg is a mechanical engineer whose lifelong interests center on developing precision electro-optomechanical systems. He is primarily focused on developing machines for the semiconductor process equipment market. He works with thermal, structural, and optic elements, as well as fluid dynamics, concept development, and design for manufacturability. Congratulations, Greg. This is Michael Metz. Michael spent his professional career as a materials scientist working with precious and rare earth metals and their technical applications. His work focused primarily on the development, production, and sale of highly engineered precious metal materials for the electronics, chemical, and medical industries, both nationally and internationally. He has a long history of board leadership in both for-profit and nonprofit organizations, including but not limited to the Makerspace Generator, of which he is a founding member, and the Burlington City Arts Foundation, in which he is also a founding member. Michael has a passion for young people and education, especially as it pertains to STEM, and he has devoted much of his retirement to supporting Vermont nonprofits that are focused on creative economy, experiential learning, and positive social impact. Congratulations, Michael. This is Dr. Richard Page. Dr. Page has served as Dean of the Larner College of Medicine at the University of Vermont since 2018. He is a professor of medicine and a world expert in cardiac arrhythmias and sudden cardiac arrest, with over 200 publications appearing in peer-reviewed journals. Dr. Page has held leadership faculty positions at numerous institutions, including Duke University, the University of Texas Southwestern Medical Center, the University of Washington, and the University of Wisconsin School of Medicine and Public Health, all before coming to Vermont. He has also served on numerous national committees, including as a fellow of the American Heart Association and an elected member of the Association of American Physicians. Welcome to VACE, Dr. Page, and congratulations. Congratulations to all 7 of our 2020 inductees to the Vermont Academy of Science and Engineering. And we all look forward to a time when we can gather together to honor you in person when the situation is safe enough to allow us to do so. This brings me to introducing our keynote speaker for the evening, Dr. Mark Levine. Dr. Levine was appointed Commissioner of Health by Governor Phil Scott in March of 2017. Prior to his appointment, Dr. Levine was a professor of medicine at the University of Vermont, associate dean for graduate medical education, and he was a designated institutional official at the College of Medicine and the UVM Medical Center. He also served as vice chair for education in the Department of Medicine. Dr. Levine received his BA in biology from the University of Connecticut and his MD from the University of Rochester. He completed his internal medicine residency and chief resident year at the University of Vermont, and then a fellowship in general internal medicine at the University of North Carolina. Dr. Levine's general internal medicine practice focused on health promotion and disease prevention, preventative health screening and clinical nutrition, chronic disease management, and solving complex diagnostic dilemmas. With this experience, Dr. Levine understands the challenges our healthcare system holds for both patients and for physicians. This informs his interest in improving public health through policies that foster a culture of health. Dr. Levine has led the way in Vermont's response to COVID-19 with a data-driven approach and a focus on the basic tenets of public health. He is why Vermont has been dubbed an island of COVID stability in what may otherwise seem like a country in COVID chaos. So without further ado, I'd like to introduce Dr. Levine, who will be talking on the application and misapplication of science, epidemiological data, public health practices, and health policy during the COVID-19 pandemic. Welcome, Dr. Levine.
Thank you very much. Pleased to be with you all tonight. It's a very wordy title, as you might have detected. It implies I'd like to have maybe sacrifice a little depth for the sake of breadth, because there's so much to cover in this topic. And certainly if there's areas that you'd like me to delve deeper into and provide more of the data that I wouldn't have time in a 45-minute presentation to present, please let me know in the Q&A. My objectives are going to be to begin to talk about the wonderful statistics you heard about just now, and detail the lessons learned about managing the pandemic thus far. We'll talk about how the pandemic has taught us very important lessons on the topic of health equity, which is a big focus of the health department. We'll talk about testing, especially the role of antigen tests in serology. We'll illustrate where Vermont has led the way in a few areas. And then, per the title, talk about some of the many controversies and misapplications, if you will. From the beginning, obviously, if you live in the same country I live in, you know that we had a very slow and inept response to the arrival of SARS-CoV-2 virus in our country. It was a novel virus. We knew little about it. We knew that travel was important early on, and we knew that once it reached our shores, we quickly, in the public health arena, found that because of inadequate testing, inadequate personal protective equipment, we were not going to be able to contain this virus in the traditional way of most epidemics. What was fundamental to our early response? Very basically, we activated our Health Operations Center and the State Emergency Operations Center back at the end of January and into February, so that we could begin making those important preparations for our first case, which of course did not arrive until the first week of March. We had a sense of urgency. It was very easy to detect because of other states' experiences that community spread was occurring, which is never a good sign early on. And we had a playbook that the CDC had prepared for pandemic flu 3 years prior, which was going to have to be good enough. And you've heard the old adage about building the airplane while you're flying it. And we kind of had to do that across this country using the pandemic flu playbook as a little bit of a introduction to that. Early on, we knew that containment would not work. Just so that we can review that topic for everybody, containment is basically, basic premise is that you have adequate testing, and that adequate testing then finds cases. Those cases are isolated. The isolated cases are then interviewed and have contact tracing, and that all of the contacts are quarantined. Simple concept, but when you lack PPE and testing, you essentially have abandoned the opportunity to pursue that strategy. We also analyzed the so-called epicurve and exponential growth of this virus. And as you've probably heard about the R0 factors, the virus having a factor of 2 or more meant that one infected person could rapidly infect 2 or 3 other people. And then you can see how that can exponentially flow. So this is the world famous diagram that goes along with that, which basically shows that in the red, if you really have not instituted any protective measures and the exponential growth continues unabated, you have a very steep ascending curve, and you come above the dotted line, which indicates the capacity of the healthcare system to deal with all of the cases it's confronting, and you have a disaster. So the goal, of course, is the now well-known statement, flattening the curve, to allow protective measures to be put into play so that one can still have a lot of cases, but not have cases overwhelm the capacity of the healthcare system. So we followed that very, very closely. And then in a very progressive manner, introduced community mitigation strategies. Final real important component of our response was having Governor Scott, who sincerely prioritizes health and safety, believes in science, believes in data, believes in working with a strong team, and was instrumental to the success that we've had here, needless to say. In terms of people milestones, first case came early March, second case 4 days later, first death a week later, our first outbreak in a nursing home just 2 weeks after we saw our first case in the state. And by the time 3 to 4 weeks had passed, we were peaking in the number of cases we had. To show you how quickly things went, state of emergency was instituted less than a week into the whole process. We had very restrictive visitation policies to healthcare sectors, to nursing homes, to correctional facilities, all the places where we believe the most vulnerable live. Quickly reduced the size of mass gatherings, knowing that this is a very contagious process. Quickly closed bars and restaurants where people would be indoors breathing on one another. And some think not so quickly, but when you look at the dates, it looks rather quickly. We closed schools, knowing that children may not have played the major role in this pandemic, but at the same time, we needed to get people more in smaller settings than big schools. And then all the other closures in other professions followed. And literally 17 days into this pandemic, we were staying at home, staying safe, which I'm sure you all remember well. That's a rapid tour of where we were to confront the virus within the first month of our experience. So people are often asking, what explains the low incidence rate we've had and the number of deaths and test positivity rate, and what are the lessons learned? So obviously, we're up to 2,000 and a little more than 16 cases now from the time the slide was made. Big peak in the beginning, which was that rapid upsloping curve that we tried to flatten and did flatten rather quickly. You'll notice at the end of May, beginning of June, another uptick. That's the Burlington-Winooski outbreak. And you'll notice where we are now at the tail end of this graph, where we have another uptick in cases, which we'll get into, but it's very, very concerning, related to some newer outbreaks, but also related to the fact that we are living essentially in a time when all the states around us are having a resurgence, and the whole country, as you know, is having very, very serious problems with the virus. That's just the shape of the curve. Fortunately, none of the slopes look the way they did in the beginning. We have the lowest number of cases per 100,000, and we have the lowest number of deaths per 100,000 of all the states. The blue areas show the number of tests being performed in the state, which are quite robust. The red line is the percent positivity of those tests. Obviously, in the very beginning, we had a positivity rate in the low teens. We currently have one that's still below 2%. We've had them as low as 0 point something percent, but there's an uptick in them now as well. But clearly, you don't want to have, you don't want to be misinformed by having a positivity rate of whatever number in the setting of inadequate testing. And that's clearly something that we have not had that problem because we've had adequate testing all along. So what explains all of that success? I always prioritize the fact that we live in a state where people enjoy good health. They prioritize health. The Commonwealth Fund, the United Health Foundation, other groups have all rated Vermont in the top 5 or 6 states for health, often the first state. So we're starting at a good baseline. So people are actually very cooperative and compliant because this is an area that they're very concerned about. We had a very strict early philosophy of protecting the most vulnerable in the various settings that I mentioned, corrections, long-term care, hospitals, etc. Not only with restrictive visitation policies, but with a whole host of other interventions that we'll get into in a second. We chose to understand what I call contact science, meaning it's the amount of one-on-one contact, close contact that's important. It's the density of contact, so crowded rooms obviously being important. And it's the duration or the intensity of contact that is also important. And educating people about those 3 features is really critical. The reopening process is successful because we waited till we had sufficient viral suppression. If there's anything that's been controversial in our country, it's when you see some of the states, predominantly in the South, that basically said, we're done. We've had it with this virus. We're reopening. But they still had percent positivity rates in the teens or 20% range and felt that they could do that safely. We chose to suppress the virus to very, very low rates. And as you recall, when Dr. Fauci was Zooming in with us a couple of weeks ago, he really wanted to uphold that as a model for the country as a way to properly do reopening. We were, I say this modestly, viewed as trusted messengers and being a trusted resource by the population. And basically, that's because the public always gets to know what our data is and how we use it. Not only the press conferences, which were 3 times a week and then now twice a week, but our website, which is full of great information, valued by the public, also has daily updates, keeping them very well informed, and weekly updates showing them the data in aggregate. And of course, they can go to the data dashboard anytime they want. The other thing is phased and gradual reopening using public health science. So the thing that you would be deceived by if you just looked at the experience of some of the states I was just commenting on is that there actually is some public health science behind how to reopen. So this is the title of a document from Johns Hopkins, worked on with the CDC, that basically provides the principles and guidance for governors. But the CDC also published a great document that unfortunately the administration almost tried to cover up. And then when it finally came out with a lot of controversy. But it had gating criteria, which were adopted by the administration, which essentially looked at what's the level of transmission and how well controlled is it in your particular state. Is it on an appropriate downward trajectory in terms of the number of positive tests you're having? Is your public health system able to do containment? In other words, testing, isolating, contact tracing, and quarantining, so that as outbreaks occur, knowing that they will, you can manage them. And then finally, is your healthcare system able to treat all new cases with the capacity to absorb the increased transmission? And, we don't have to get into great details about these gating and phases, but obviously the phase 0 means everything is uncontrolled and you need a lot of help and you shouldn't be opening anything. And as you move through phase 1, 2, and 3, you have various amounts of either significant controlled transmission or very low controlled transmission, and implement different mitigating strategies along the way, which is exactly what we did. And every time you heard Governor Scott refer to the quarter turn opening of the spigot, that's exactly what we did, is do something modest and then wait the requisite 14-day incubation period for the virus to be sure that what we had done did not severely distort the statistics we were getting and show that we were going backwards in any way. And we were able to do that very successfully, but as you all know, it wasn't in one fell swoop like many of the southern states. It was a very phased, graduated process. So, in the lessons learned slide, what did we learn from all of this? First of all, asymptomatic spread should no longer be a controversy. It should be a given. Now, there have been rates as low as 4% and as high as 32% to explain asymptomatic spread. But the bottom line is a very recent review of the entire literature thought it could be as high as 40%. Clearly, what we've learned in many of the outbreaks we've already managed here in Vermont and around the country is that there are many people who are in a pre-symptomatic phase or who will never become symptomatic, who have very high viral loads and capability of transmitting virus to others, even when not coughing or sneezing, just with talking or singing. We learned that simplified guidance is something we should actually continue to do because it works. If you tell the population some very simple messages, wash your hands a lot, stay home if you're sick, wear a mask, stay 6 feet away, and you keep it that basic, you can actually get some traction. There will always be people you can never convince or who don't believe, but at the same time, in a population like Vermont, many, many people actually accept that and understand it. And if you've explained it well, it's easy to remember. We learned that containment works, much different than when the pandemic began, when we had no opportunity for containment. We actually learned that if you have testing and contact tracing capacity, you can put out epidemics and outbreaks like the Burlington-Winooski outbreak. Now, over time, it doesn't happen overnight, but you can do that successfully. You need an adequate workforce. You need adequate testing supplies and collection supplies. You need to strategically target populations that you know could be good sentinel populations or that are vulnerable. And one hard lesson we learned is you need to stockpile whatever you have, whether it's collection supplies, whether it's reagents. You don't want to get burned again like we did in the early parts of the pandemic, where those were very, very rare commodities. We learned how to protect the most vulnerable. The restrictive visitation policies helped. Testing policies when cases arose. We basically learned in a long-term care facility that a case is a national emergency. You need to go in quickly, test the entire facility, staff and residents, have specific protocols available so that you can isolate and quarantine those necessary. And most importantly, cohort-like patients with like patients, cohort staff with only certain patients and not let them cross over to patients who do not have the disease. We also learned that the most dangerous time in a nursing home is when a new admission arrives or a person who, say, is on dialysis, who's coming and going from the institution because they have that healthcare need. So you need protocols for quarantining those people and for having elaborate multi-day testing protocols to make sure you protect all of those in the institution from these new admissions. One thing we learned without a lot of rhetoric is public health and economic health can exist at the same time, and you can reopen and balance risk. That was not hard for us to be able to show here, but I think it's impossible to show if you don't have a suppression rate of virus when you start to reopen. Having a high level of percent positivity in tests is very, very challenging to being successful in opening economically. So we have data and metrics we use as we open the spigot and as we watched our data to make progress. And the four key categories are syndromic surveillance, viral growth and reproductive rates, percent positive tests, and the healthcare system's capacity. And just very simply, pictorially, we have here the percent of emergency department and urgent care visits for COVID-like illness. That's what the fancy term syndromic surveillance means, just how many people are presenting to those settings with the right symptoms. Clearly, you could see that the only time we've had a preponderance of those was early in the epidemic. Second is this average daily incidence by date of report. And you can see the early spike we had in March. You could see the Burlington-Winooski spike. And now you'll notice another concerning area on the right side of the graph where the baseline actually is a little higher when we started, and now we've gone up. And that's related to the Central Vermont hockey instance, a social event in Lamoille County, and now further spread of the Central Vermont process to the St. Michael's College campus. And then here's percent positivity, the blue line showing the number of tests per day, and the bottom darker line showing the percent positive tests. Even currently, we're still only around 2%, but we've been even lower than that. I didn't prepare a slide showing the healthcare system's capacity because it's been months and months and months where we've had 0 to 3 people in the hospital per day. And the hospitals are up and running, as you all know. And the goal is going to be to watch our data very carefully to make sure that we're not approaching any kind of a surge that would require the hospitals to open up capacity before it was too late. This is just deaths. We haven't had a death in almost 3 months. That's a little hard to fathom even, but so far so good. We'll see how long we can keep that run going. The final lessons learned, one that I'll get into at the end of the talk with the misapplications, is how everything is potentially controversial. Everyone is an armchair epidemiologist. Everyone knows if there really is a pandemic or isn't a pandemic, if the deaths actually matter, or if these were people who were going to die anyways, etc. A lot of hard lessons there in trying to make sure that we could manage public expectations appropriately and convey knowledge and not myth. The other interesting thing is originally it was thought that rurality would be protective, and that might explain why Vermont could do so well. But as many of you know, even though early on some of the cities had a lot of problems, the majority of the second surge, the second wave that was in the South and Mid and West, and now in the Midwest, actually began with a much younger population and began in much more rural and suburban areas, showing that the virus is everywhere and you're not always protected just because you're in a less urban setting. The major other lesson learned is health equity, which I'd like to spend a couple minutes on, because those who have heard me speak before know that one of the tenets of our state health improvement plan in Vermont is a foundation of health equity. So what is health equity? Think of health equity as really the opportunity, having a fair and just opportunity to be healthy, especially in those who've experienced some kind of historical injustice or disadvantage. And obviously, these avoidable systemic inequalities are associated with the usual players, if you will: race, gender, ethnicity, sexual orientation, socioeconomics, disability. So health equity and the opportunity, fair and just opportunity to be healthy. Obviously, this all sits on the so-called social determinants of health. On the left side, interpret economic stability in the inverse as poverty. Second column, the physical and built environment that people find themselves in. So consider that to be, do they have adequate housing and transportation? Third column obviously surrounds education, and the fourth column is really food security. The thesis here is that obviously all of those need a tremendous amount of work in our society, and if you want a healthy population, it's not the health care they receive, and it's not even the opportunities to access that health care. It's much more fundamental factors that explain what kind of health or illness they have that usually rest on all of these social determinants. And these social determinants are all determined in many, many cases by some of the historical injustices, such as systemic racism. Looking at COVID is fascinating because it sheds a light on health equity in a powerful way. So you'll see here that if any of you know the constitution of our population in Vermont, you know that BIPOC, meaning Black, Indigenous, people of color, do not account for a quarter of our population by any means. But they do account for a quarter of our cases, and the rate per 10,000 is 4 times that in white non-Hispanic. The hospitalization rate is also statistically significantly different and it's about 2.5 times that in the white population. There's a tremendous difference in the amount of chronic disease, which of course makes you more susceptible to a severe course of COVID. And some of those diseases are on the right-hand side, which are what you'd expect: diabetes, lung disease, cardiovascular disease. So what are the factors that contribute to this and lead to some of the disparities? Well, if you believe what I've said about systemic and structural racism and other oppressive systems that affect the conditions in which we all exist, you can see that it's a recipe for disaster if you're in those populations. First of all, there are higher rates of underlying medical conditions in those communities. And that does not mean that it's a purely genetic predisposition. So that's why one has hypertension, cardiovascular disease, diabetes. I kind of look at it as the genotype may be there, but the phenotype is exposed in the living conditions that people find themselves in, which allow that environmental connection to allow these diseases to take off and prosper in those populations. People in these communities often have more exposure at the workplace they have because they're not able to do teleworking. They're basically in jobs that have a public face. To get to those jobs, they often have to take public transportation as well. And illustrated well in our Winooski outbreak, but in many others around the country as well, multi-generational housing and congregate living spaces play a big role. So obviously, the solutions to all this do not occur overnight and involve addressing these basic fundamental historical injustices and racism, but there are some other necessary things that are on the following slide. And one lesson that we learned as the Department of Health is, even though we thought we had things in a lot of languages and interpreted well, we had some populations that actually weren't accounted for that needed to be. And we needed to work with a lot of community partners to achieve success. So our whole state health improvement plan is based on health equity. We never looked at it through the COVID lens because through so many other lenses, it became obvious. But here, indeed, we had to be very, very respectful of the fact that we had to learn some lessons and and they paid off tremendously when we got to some of the other outbreaks we encountered subsequently, which also involved populations that were not white, non-Hispanic. I want to also follow on with something about testing and contact tracing. I'm segueing to another part of this discussion now. And in this section, I'd like to talk about how much is enough, the role of antigen tests, serology testing, and lessons we've learned here. Way back in the beginning of the pandemic, researchers at Harvard were able to actually come up with a suggested minimum testing for states' populations. Some of this was based on the experiences around the world and a number of other epidemiologic considerations. But the bottom line was 152 tests per 100,000 people per day, which in Vermont explains where we got to 1,000 tests per day, which we far exceeded, by the way, at this point in time. If you look at the graph, we were at 1,000 tests per day at the end of May, and it's only gotten higher. I will say that the part that gets very high in the end of the summer and the beginning of September is accounted for by the additional testing of the college student population as a condition of their returning to school here and reopening college. But even without college, we often have days that are in the 12 to 1,500 tests of non-college students. So we're not fooling ourselves when we look at the data and our percent positivity rates. Antigen test is something that has made a lot of news and controversy, and we've contributed to that in Vermont. Many of you know about the Manchester Medical Center issue down in Manchester and surrounding areas, where essentially a whole host of positive tests were found. Only half a dozen or so were verified by PCR testing subsequently. And in interviewing all of those who were positive, it was evident that many were not symptomatic or didn't have classic COVID symptoms. And then in further testing the entire community with about 1,600 tests from pop-up sites throughout the region, we only found a couple more cases, indicating there was really no major community outbreak occurring. So this taught a lot about the role of antigen tests, because it turns out that antigen tests work best at a time when there's a higher prevalence of the condition in the population, and specifically when people are symptomatic. So it's very important to use antigen tests at a time when you're seeing a lot of cases and there are people who are symptomatic, because you can quickly test them and then triage them in the appropriate manner. Antigen testing in asymptomatic populations has been discouraged because they're not as sensitive, so there'd be more false negatives, and there's an opportunity in that population to have false positives as well, because as you might imagine, in an asymptomatic population, when there's a low prevalence of virus, most positive tests are going to be false positive. The evolution of this, we basically published a HAN, a health alert notification, which has gone to all clinicians in the state. A lot of the national news picked up on our episode in Manchester, but also was beginning to pick up on other places around the country where similar events were occurring. Private firms have been doing workplace testing in Vermont using antigen tests. And the federal government has 150 million test cards, the Abbott Binax cards, that they wanted to and have now distributed to long-term care facilities throughout the country. Turns out you can use those cards, but you must use them in a way that you're doing regular periodic testing of the population, meaning you can't just administer them once, like or once a month or what have you. You need to do them once a week, several times a week, constantly, so that a positive will have true meaning in that population. States have started to use them because the government gave them for free. And Nevada started to use them and had an experience very similar to the one we had early on in our use of antigen tests. And basically what ended up happening is Admiral Giroir, who is the Assistant Secretary of Health in Washington, basically threatened Nevada because they had decided to halt using these tests because they were getting too many false positives. So controversy continues to reign, even in something as, I think, epidemiologically understood as antigen testing. Serology testing, which is antibody testing, question is always asked, is there a role? We don't believe there's a role in the acute setting because the acute setting is really one that mandates using either antigen or PCR testing for. But there is a role in population level data. The challenges are, of course, that many of the tests offered have poor sensitivity and specificity and performance characteristics. We have used surrogate testing, meaning the Red Cross sends us a report every month letting us know of all those people who've donated blood, what's the percent positivity from a serology standpoint. The CDC is also doing seroprevalence studies in various places in the country as another sort of surrogate for understanding our nation's experience. The bottom line is, with the amount of virus we've seen in Vermont, we're always going to be under 5%, and we've been really in the 2% range. So we don't believe serology testing plays a major role for us here. You know, you'd have to ask, what good is it going to do somebody in the future? And it doesn't really have a big role in clinical decision-making right now. So other testing lessons learned have to do with using a diversified portfolio, meaning not just one testing platform where you run out of reagent and you're done, but having multiple platforms across the state. Trying to use nasal swabs to make it a user-friendly process for the person so they don't undergo what people fondly call a brain biopsy with a nasopharyngeal swab. And then just understanding that the FDA early on gave emergency use authorization for many testing platforms, and they had to pass very basic validation testing for sensitivity and specificity, but not a lot was really understood about how they perform in the clinical setting. And it turns out, though they may be exquisitely good at finding small amounts of virus, when you apply them in a clinical setting, all bets are off, because that has to do with how well things work in the lab and quality controls there, how well you've collected the specimen, and did you do it for the appropriate amount of time, swirling the swab, etc. So a lot of lessons learned there. But the bottom line is Vermont's become a leader in its testing in terms of being in the top states for having the right amount of testing and understanding its testing. Contact tracing, we're cited as being the very top in the country because we interview people so quickly and comprehensively. Part of that, I think, was rigged because, again, we have a population who picks up the phone and talks to us. In many places around the country, that's not true. The risk of becoming a case after being a contact has always been about 10% or less in Vermont. And the highest group is household contacts, where it can be up to 20%. A couple other places where Vermont's sort of made its name. First of all, recent report came out in the Morbidity Mortality Weekly Reports based on a incidence in one of our correctional facilities. Non-consecutive brief encounters not meeting the close contact definition might be an unrecognized exposure source for SARS-CoV-2 transmission. What essentially happened is when the 6 inmates from Mississippi transferred to Vermont and promptly became sick and COVID positive, acquired in Mississippi, a correctional officer who, if you use the traditional 6 feet away, 15 minutes or more contact, would not have been considered to be a close contact. But that correctional officer came down with a case of COVID. Turned out, and this is why it was publishable and why it changed CDC practice and national guidance, that we had a great videotaping system in the prisons, and every move of this correctional officer with the inmates could be monitored. And it was quite clear that he had very small but frequent contacts with inmates who were COVID positive, some of whom weren't wearing masks, but the amount of time was not sufficient to make the 15-minute rule in a prolonged way. But when you added up all of the individual contacts cumulatively, they did qualify. And this has now revolutionized how contact tracing is being done. The other thing we've done in Vermont, and many of you who've traveled may have tried this even, is to try to get out of quarantine, which is a 14-day period. One can get out on day 7. And here we have the incubation period of coronavirus disease from an Annals of Internal Medicine article in May of this year, which essentially said that by day 7, such a high majority of people had already become symptomatic. And certainly by day 10, there were very few people left who would not become symptomatic between day 10 and 14. So we've used this very successfully to allow people to test on day 7, which means they get out of quarantine on day 9 or 10, depending on when their test comes back. And only 3% of people have had any symptoms develop in days 10 through 14. So it's worked well for the population here, and I think increased compliance with quarantine. The final part of my talk is the misapplication section. First of all, children. What role do they play? The risks in schools and childcare and of child to adult transmission. Turns out less than 6% of the cases in our country are in children. In Vermont, it's a little higher, 13%, and I think that's because some of our outbreaks, like Winooski, involved huge families that had a lot of children. As you are probably aware, the angiotensin converting enzyme 2, ACE2, has age-dependent expression in the nasal epithelium, and that has been used to explain why children do not seem to get infected as often, because it's an age-dependent expression. The bradykinin hypothesis, which is one of the cascading events that occur through the renin-angiotensin system, basically has been used to think about the major inflammatory process that COVID represents to those who get very ill. There was a question early on, and clinicians early on were willing to take people off of ACE inhibitors, which are used in heart failure and blood pressure treatment. And they basically have now been studied well enough through numerous very recent studies to show that that does not appear to be a risk to that population. Here's just the schematic of the ACE2 receptor and the virus entering the cell by attaching to that receptor. I wanted to show a little data on the children. In Vermont, we didn't actually test children till June or so. They now represent 13% of the cases, but a third of those are in the 18 or 19-year-olds, which you could argue are closer to being adults. The numbers increased in time, a little skewed by the advent of testing college students. Interestingly, though we have these symptom checklists all the time, many of the children do not present with fevers. 3 out of 4 of them do not have a fever, though they may develop it during the course of illness. And on the right side, in those bar graphs, you can see that the percent of COVID cases with no symptoms is higher among the very youngest than in any other age group. Less than half of cases among children had no symptoms reported, but 44% is a big number. Older children clearly have the higher rate, sort of satisfying that theory with the ACE2 receptor. And the BIPOC community, again, in Vermont, disproportionately represented with a massively increased rate compared to whites. Finishing up with a few more misapplications. Cherry-picking studies to fit one's purpose in a time of rapid change and evolution of knowledge. I would think that, first of all, this whole issue of the children transmit the virus, there's abundant epidemiologic literature that shows that in schools around the world, the majority of time children have been positive for COVID have been when an adult brings the virus to school and infects the child, and not in reverse. And there's been very little evidence for within school transmission causing significant problems. Nonetheless, when we reopened schools, people wanted to pick on the one study from Korea that actually came out on the opposite side of this issue and suggested that kids were dangerous and adults shouldn't be in the same room with a whole bunch of them. Our experience in Vermont has gone much better than that, but I would caution everyone to again remember the K through 6th grade group is much different than the middle and high school group, who do and can behave more like adults. Fortunately, in the K through 6th group, they need the in-person education the most and can have more days per week to benefit from it. Another example of cherry-picking studies is it really significant that people have died from COVID, and are there really excess deaths? Well, it's been well demonstrated to this point in time that there are indeed excess deaths. And though, yes, many older people have died from COVID who did have a lot of comorbidities, that doesn't mean they were destined to die at the time they did. It was the COVID that pushed them over. Does airborne transmission matter? It took a long time, but finally the WHO and now the CDC agree that some percentage of transmission is through aerosols. Most transmission is probably through large respiratory droplets, which the masking is tremendously helpful in, so that we are altruistic to our fellow Vermonter and don't cough and breathe droplets onto them. However, with aerosol transmission, it actually turns out that perhaps the mask is protecting one from some of the aerosols that hang around in the room and don't settle out so quickly. That's becoming more and more clear, though it's still not clear if that's a major mode of transmission. It's probably a minor mode. It's very obvious that in a pandemic, literature comes out quickly at a fast and furious rate. And journals do continue to have editorial review, obviously, but the number of studies that have been retracted is remarkable as well. So one has to be careful as this literature is looked at. What I've listed as loss of humanity, the minor chance of becoming really ill, people often think that, well, 80% of people do fine with COVID, only 20% develop more severe illness, and that is true. But they don't realize that within that 80%, there are a lot of people who actually don't feel really well. Not only is the illness knocking them for a loop, but now we have this thing called the long hauler syndrome. We don't know how many people it affects because we're still too early in the pandemic, but it's wondered if perhaps up to 10% of people have long haul symptoms, much like what people would get when they used to call the syndrome chronic fatigue syndrome, which now has a much fancier name, but the kind of symptoms that don't go away and that leave people much more debilitated than before they got the virus. And indeed, knowing that 37% of adults in America are either obese or have diabetes or other underlying conditions, there's a lot of us at risk for this illness. Observational studies versus randomized control trials. I'll say a little word on that in a second. And then I don't have to say much about the politicization of public health guidance that's occurred, most recently, of course, with promising a vaccine before Election Day. Herd immunity in Sweden have been major misapplications, if you will, that we need to consider. I consider Sweden to be a failed experiment. Their death rate is not insubstantial by any means, and their economy was not able to achieve the success they had hoped for by infecting everybody in the population by not adhering to a lot of public health guidance. Nonetheless, you've heard Dr. Atlas, who is President Trump's latest advisor, who is a full fan of this, even though no one else in the coronavirus task force will talk about it. Masking, I don't have to say much more about the controversy there, but the fact is, we're now finding out that even within states, you can find parts of states that mandated masks that have better statistics than the parts of states that didn't. And there are now studies going on across the country of states that have mandated masking versus not. And some of the evidence that I've been reviewing shows that mask mandates are actually a successful public health strategy. I'll just move down quickly because I want to finish up and allow questions to the PrEP Act. That was the slide I showed you of Admiral Giroir in Nevada. But an actual act saying states cannot preclude long-term care facilities from using antigen tests, which to me is a bit heavy-handed when it comes to the application of appropriate testing in healthcare settings. And then the values of therapeutics is where I want to close. So we've come a long way, and we know a lot more about how to treat people than we did early on, but clearly the timing and use and amount of supplemental oxygen, including heated high-flow nasal cannula, the use of some strategies, either in a ventilated patient or a non-ventilated patient, of prone positioning, being successful at aerating the upper lungs, and in the ventilated patient using a lower tidal volume. Antiviral drugs, the FDA has just approved remdesivir as the first real antiviral drug that has efficacy in this condition. Unfortunately, the studies have not shown survival benefit, but they have shown improvement in symptoms and duration of symptoms. And then dexamethasone is the big success story, but really, in spite of the experience with President Trump, only meant for those who are in the severely ill end of the spectrum, usually in an ICU, where it really interferes markedly with the inflammatory mediator cascade that's going on. Possibly monoclonal antibodies. In terms of the thumbs down area, antiviral drugs like lopinavir, ritonavir have not borne out. Hydroxychloroquine, with or without azithro, has not borne out. Convalescent plasma, not yet. There are some encouraging studies going on with immune modulating drugs like tocilizumab, and we'll see where that ends up. And then anticoagulants, because if you've read about the illness people get with coronavirus, there is a propensity to being hypercoagulable and clotting, leading to such sequelae as strokes and other bad outcomes. So the institution of anticoagulant therapy in an earlier fashion for those most severely ill seems to be efficacious. Those studies are still ongoing to prove that. So I know I've covered a lot, and I will stop there and allow questions if there's time. Thank you.
So thank you, Dr. Levine. So I'm going to start with the questions. But before I start with the questions, I wanted to Thank you for keeping Vermont in such a great shape in the midst of this pandemic. And so the question I have coming from the Q&A has to do with, I think it's related to a report on NPR this morning, where it was reported that over 65 colleges across the nation have turned to wastewater testing to monitor coronavirus spread. And the question is, do you see any role for sewage testing for surveillance in a setting like ours with a low prevalence to provide early warning of localized outbreaks?
I think the role is being defined. The city of Burlington is actually doing that in a few locations. And the data has been a bit conflicting that's come out of that. It is, I think, an early warning signal. The question is it worth investing in that as the early warning signal, or can an appropriate testing strategy accomplish the same? The reliability is yet to be determined. I know a number of colleges have adopted that, and I have no problem with that. But I'm not sure that, it has been rather expensive, and I'm not sure that its value outweighs the expense at this point in time. We haven't found a huge correlation in the small amount of testing that's been done in Burlington as of yet. But I have a very open mind, and as the science gets better developed, certainly would entertain it by all means.
Thank you.
Dr. Levine, this is Emmett Hewlett. I have a question submitted by Carleen, and it is, are there ventilation systems appropriate for schools that should be considered to make in-school learning safer?
There are. The problem is that it requires a rapid process in the school, which is usually not realistic at this time, and it can be very expensive. But there's systems that, one, involve flow, and two, involve ultraviolet radiation in a safe manner, though. And that's what we've been working with schools to advise them on, if you will. I think the reality is we have a lot of schools in Vermont that are older. We have schools that have quickly got their student bodies back in person learning. And I'm not sure that it's within the financial framework of their current operation to be able to all of a sudden institute some of these newer systems. It's the one part of the pandemic that I think is the toughest to deal with, because you can have communities that are the haves and communities that are the have-nots, and you'd hate to determine outcomes and safety in those communities by their resources and perpetuate some other underlying challenges that are already there. And it's the one place that just nationwide has not been attended to the degree that we would like it to be, especially now that everyone's going indoors and soon windows will be closing and it won't be feasible to keep them open. So this is a real challenge, to say the least. But our hope is that at least some of the systems that some of the schools have will be sufficient at this time. The good news is the student bodies and the staff and faculty at schools around the state have been so good about physical distancing, masking, hygiene, everything we've asked, that hopefully they're going to stay on top of things because they're so compliant with all of these.
So the next question, Dr. Levine, is coming from a new board member, Bryan Ballif, and his question is, can you provide any update on the likely time frame for deploying a vaccine in Vermont?
Yeah, we're busy at work on that. So a week ago Friday, we submitted our plan to the CDC. Just got the report back, which was pretty glowing, actually. hardly any recommendations, and they were very minor recommendations, but thought the plan had a lot of strengths. It's still a real challenge to answer the question, will there be a vaccine before the calendar year changes? There could be one, perhaps. And if there's one vaccine, you can imagine how many millions of doses they'll have to distribute to 50 states plus DC, so that any state will have a very small amount. And it will probably go to states that are having more of a surge problem than states that are not having such a problem. But the bottom line is, we will be ready for the vaccine when it arrives. We'll have to give it in a phased way. So the first phase will be those who are healthcare workers and in the highest risk group. The second phase will be those with a lot of public contact, public facing, like teachers, for instance, and other higher risk groups. And then the third phase will be more of the general population. And mixed into those first and second phases will be the very vulnerable, such as the elderly. We're not so worried about how to get the vaccine out to the people who need it. We're worried about how much vaccine we'll get at any given time. If we use our H1N1 experience from many years ago as an example, some days you would get hundreds of doses for a state of 600,000 people. And even if you got thousands of doses, you can imagine all of the ethical and other imperatives that come to mind when you decide how you're going to actually distribute that number of doses to a large population, not knowing how many more might be coming in the next day, week, or month, because it's all dependent on manufacturing capacity and the federal government's decision-making regarding distribution. So very hard question to answer, but I can just reassure you that whatever we do get, we will be ready to distribute.
Dr. Levine, this is from Frank Winkler, also a board member, and it's associated with the vaccine discussion. And his was focused more on how will the state assure Vermonters that the vaccines are safe and effective? And how do you plan to urge Vermonters to get vaccinated?
Good questions. So I'm going to piggyback onto Dr. Fauci and others who basically represent and believe in the scientific community and know that you can't politicize this in the way it has been politicized. The FDA's already tried to dissociate itself from that and said that they will only have the blessing of the scientific community. They will make sure that any vaccine has had a 3-month period of time elapse to make sure that nothing untoward has developed before they distribute it. So we'll have the results of these phase 3 and higher studies and understand efficaciousness as well as adverse events and their nature. So, like everyone else, we'll be evaluating the vaccines on that basis. You have to understand that there are many vaccine platforms, some of them protein-based, some of them nucleic acid-based, and there are many different storage requirements in terms of refrigeration versus ultra-cold freezing. And there are potentially many different efficacy results one can get depending on what exactly the vaccine is based upon. So it's going to be a complex evaluation, and it's going to depend to some degree on how many actually make it to the finish line and what we know about those in total. So not easy questions to answer by any means. I do know that in messaging to the population, you start out in a better place if you're already a trusted messenger and people at least will listen to you. But there is a fair amount, even without the current politics, of vaccine hesitancy in our population in general, not just in Vermont, but across the country, but certainly in Vermont as well. So it's not just saying when, why this vaccine should be taken and why it's in your best interest. It often is more fundamental to a whole notion of why we have vaccines, why we think vaccines are important for your overall health, and how this one will then help you even further. So it's a very challenging communication exercise. The last thing in the world, though, you can do if you want to have good uptake is to mandate the vaccine. And I think that mandating is really a very poor option, if you will, because that creates even a higher level of resistance than if you gave people some freedom of choice, but good education.
Dr. Levine, a follow-up question that I'm getting pinged on by all the members is how can we at VAIS help get that message out? Is there anything that we can do to be of assistance?
Yeah, definitely. I think this is where the scientific community can, have a unified message if it's warranted, obviously. So if we feel that we've had adequate data to analyze and we understand the results of the trials, we understand the strengths and weaknesses in the design of the trials, we understand the limitations in terms of the size of the trial and how they might or might not determine every adverse event that might occur, knowing some could be quite rare. I think we need a unified scientific community. Even if one specialty is not vaccines and evaluating those kinds of trials, understanding the science behind what's being advocated for and understanding the study design and interpreting the analysis of the study and the results is critical. So I do think there's room for lots of voices in the biomedical world, if you will, if I could call it that.
So, Dr. Levine, this next question will require to go back in time before March 2020. It seems like a lifetime ago. So it's pretty clear now that this coronavirus is different from SARS and MERS. And so going back to January or February, when did you actually look at the data coming from overseas and started to think about how to implement a response from the state? Because the state was very quick from the first case to the state of emergency was less than a week. So we're curious to hear, when you looked at the data and realized that this was not going to be something similar to other coronaviruses.
Yeah, I'm certainly thinking later, mid to late January, I actually presented to the entire cabinet saying this was out there. We need to be very cognizant of this, be very aware, be prepared. And shortly thereafter, probably right before February, we started our Health Operations Center, and then on its heels, the State Emergency Operations Center. So the planning was beginning as early February. And of course, it was still another month till we saw a case. And I can't remember the exact date in February when Washington State saw that one case that was the index case in our country. But the moment that happened, it was really gearing us up into high gear, because once it's on the continent, it's quite obvious through travel that the opportunity is going to be there for it to spread. I think I answered your question with that. I mean, that's sort of the time frame where things happened. And it wasn't like a need to convince people within Vermont, at least within Vermont government at that time. There wasn't really any skepticism at all. And I think the benefit of having an H1N1, a Zika, an Ebola experience, even when some of those didn't cause tremendous issues in our state, but the preparedness had already occurred so that we would have been prepared for the worst. I think everybody already knowing that, and that this was a respiratory virus, which really changed the equation, made it quite clear that we didn't have a lot of skeptics, and people were like willing to listen to us and work with us and do all the preparatory work that was necessary.
Thank you.
We're coming close to the end, but I think there's time for one more question. And this one, Dr. Levine, seems purely technical. It's very interesting, in my opinion. This is from Doug, and it is COVID-19 considered to have a low dispersion or K factor? I think that's associated with super spreaders, but at any rate.
Yeah, I wish I could answer that because I don't know its K factor so much. One of the mysteries of this virus has been that it does seem to create havoc in the setting of a super spreader. And it's unpredictable when that occurs. There are very well documented times in the literature where there has been super spreading as the explanation for what occurred, but then there's plenty of other opportunity for just sort of general community spread at a lower level that doesn't really culminate in a major super spreading event. So I don't know if we've even established the answer to the question because it's not coming front of mind to me. I've studied a lot about this virus to this point. I just don't know if we have that level of certainty yet.
Thank you. So in the interest of time, I think we're going to go back to Grace.
Yes. Thank you, everyone, for attending. Thank you, Dr. Levine, for doing more than your share in keeping us safe in the state of Vermont, and for taking the time to speak with us today. It was a very, very interesting talk. I know I learned tremendously from it. Thank you also, Jonathan, for helping to keep this format going without a glitch, as far as I'm aware. Fellow board members for helping to present questions to Dr. Levine. Congratulations once again to our new inductees. Please, everyone, visit the VACE website. There you will find announcements, calls for small equipment grants and host grants for the spring, an announcement of our spring meeting. Hopefully it will be safe in the not too distant future next spring to meet in person. And of course, we want to, again, celebrate our new inductees when it's safe to do so. Again, thank you, everyone, for attending. Be well and stay safe.